Brandy, any luck?
No, it still says key graded assignment.
So you're not seeing it in your to-do list, you're not seeing it in your grade book?
No, I don't see it at
Ha-
all.
Have you
My grade
refreshed?
book. Hold on. Hold on.
Okay,
Oh, okay, I got it. I got it.
awesome.
All
Okay,
right.
sounds good. Don't start the quiz yet.
Okay. I'm not on camera, so
There you are. All I can see is your forehead. Clarence, all I can see is your forehead. There you
I'm
go.
sorry, I have a blanket. I'm kind of chilling back,
No worries.
feeling under the weather today.
Oh, let's see. The only one we're missing is Latanya. But we'll go ahead and get going. Hi, Celine.
Hi.
All right, so today we're going to do quiz 3 at the beginning, then we'll go through quiz 3. Um, and then we'll review the content from weeks 4 and 5. You already have your study guide. I sent that out last weekend for exam 2, right? And then next week we'll cover week 6 and we'll do a case study next week, and that should be the end of content for the second exam. Okay? Does anybody have any questions so far? I posted exam 1 grades over the weekend. Some people have reached out to me to schedule. If you score below a 78, I really do need to meet with you if you haven't already reached out to me. If you still want to review your exam above a 78, of course, happy to do that. So congratulations overall. This class did very, very well. So very proud of you. Appreciate your engagement, your preparation, your dedication. Keep up the good work. Keep up the good work. Um, I want to share, just so you know, we have next week we have review sessions. Okay, and you have this from week 3, the updated version. Okay, but I just wanted to review with you. And I highlighted in yellow if you want to jot it down, but you also have this. Here's the 3 exam reviews for next week. Professor Ford does hers on Tuesday, the 13th. Okay, 8 a.m. Eastern. I do mine a week from today, after class, 11 a.m. Eastern. And then Professor Kershaw does hers the Sunday before the week of the exam on the 18th. So there's your 3 reviews. I just want to point that out to you. So we got that going on next week. Next week is already week 6. So, okay. I think I have everybody here now. So go ahead and start quiz 3. Will take 15 minutes. Let's see, it's just 9:03. So let's just go to 9:15, see how everybody does. Make sure you submit it, okay, before we can go over it, and you can find it in the grade book. That's where you find your quiz, in the grade book. Okay, so everybody, let me see, make sure I can see everybody. Hannah, yep, there I can see you. Clarence, I can see you. Okay, so go ahead and start the quiz. I'm going to mute myself and mute everybody. And then we'll come back in like 15 minutes, 12 minutes. All right, but take your time. When you're done, don't forget to upload, okay, or submit, please. Do I have anybody else still working? Okay, Om and Latonya. Okay. All right. Everybody done? Yes? Submitted? I'm looking at Simone. She looks like she's still reading. Okay, if everybody could come back on camera, I'd appreciate it. How'd you do? Skylar gave me the. Hannah, you there? Simone, you all done? Okay. So I need Skylar to come on camera and Hannah to come on camera. Okay, let's review this. Did you read through your week 4 and 5 notes? Were the notes helpful to take the quiz? Yeah? Okay. Let me share my screen here. Okay, can everybody see my screen? Yes, no? Okay. So please don't be afraid to come off mute and help me here as we talk about these questions. The first one is PTSD. The nursing is assessing a client with PTSD. Which of the following would be an expected finding? From your readings and your preparation, which answer is correct?
The one with nightmares and flashbacks.
Okay. Yep.
Number 1.
Yep. Everybody get that one right? Anybody get that wrong? And if so, what did you choose? Okay, let's move on to question 2. What statement can be applied to blood alcohol concentration? What's the correct answer?
C.
C. The one thing, and we'll go through this when we go through the content. The one thing that's important about this question is that a lot of times students misunderstand and think that the only way a blood alcohol concentration is measured is by how much you consume. And we know that's not true from our notes, right? Has to do with lots of different things. Metabolization, how quick you metabolize, how have you eaten before it, what are you drinking, how much, how fast. Okay, so we'll get to that when we get to the notes. Brandy, I can't see you. I'm looking at your wall. There you are. Okay. The nurse prepares to care for a client with anxiety. What might the nurse observe? Select all that apply. What are the 2 correct answers here?
May have another mental health issue such as major depressive disorder or substance abuse.
Yep.
And then impairs the person from functioning to their fullest extent in everyday life.
Yep. Those are the 2 correct
However, I
answers.
got thrown off on this one, so that's why
Pardon
I
me?
wanted to answer this one because I got thrown off a little bit. I picked those 2, but I also picked heightened perceptual field and is aware of the anxiety because most of the time people are aware of that feeling. And I feel like it does put you in that like fight or flight distress mode. And it does heighten your perception of everything around you. You are really aware and stressed out and anxious. So I don't understand why that wouldn't have been a correct answer as well.
Well, that could be for some people, but it's not a general common observation. Okay, it also depends on what kind of anxiety it is, right? Whether you have a heightened perceptual field, but generally that's not true. For some it might be. Okay, so that's why it's not a correct answer. Right?
Okay.
Where we know that A and D is common.
Mhm.
Question 4, the nurse is working with pregnant teens and the focus is for long term. Which do we want to identify? What's really important long term for pregnant teens? This is straight out
The
of your
second one,
notes.
education.
Education, right? Why do we work so hard to try and develop programs and allow moms to finish their education? What benefit is that for them? This is in your notes.
So they get a better quality of life and best quality for the baby.
Mm-hmm. Yes. It gives them a better chance at, pardon me, better decision making for future decisions or present decisions, right? Number 5, the culturally competent nurse is leading an in-service for nurses on the care of LGBTQIA population. What statement by the nurse conveys what this acronym means?
C.
This acronym reflects gender identity and sexual orientation identities. Did anybody get that one wrong? Okay, good. And I can only see a few people. Once I share my screen, I can't see everybody. So I see head nods, at least for the people that I can see. So please speak up if you have any input. Which of the following should be the initial, important word, initial. So the first consideration made by the nurse who's working with LGBT families, homeless families, pregnant teens. So essentially, vulnerable, very vulnerable populations. What is the first thing we have to consider?
Our own feelings,
Right.
our own, like prejudices and stuff.
Yes.
And keep
Yes. And that's
them
going to come up
out of it.
that's going to come up several times in our notes today. When we care for certain populations, we have to have an understanding of our own personal feelings. Do we have any biases? Do we have any prejudices? Do we have any values, beliefs that are potentially in conflict with caring for certain kinds of vulnerable populations? So that's the initial thing we need to think about, is exploring our own feelings. Good, good. Which intervention isn't appropriate for the care of a client undergoing alcohol withdrawal? Hopefully the word isn't jumped out at you. So what's the correct answer here?
B.
Pardon me?
B.
Number
B.
B.
Right? Everything else we want to do. We want to be monitoring vital signs, providing a safe environment, addressing hallucinations if they're present therapeutically. And we definitely do not want to maintain NPO status, right? We want to be pushing fluids, correct? The nurse is assessing a client with a binge eating disorder. The nurse understands which other comorbidities are commonly found with this disorder. What are the two right answers here? Typically, the comorbidities are family history and depression, right? Family history and depression are the common comorbidities found with
Can
clients with
I
binge
have a-
eating disorders. Go ahead.
I have a question. Where do you find, because I went over the concept maps before the test
Mhm.
and I couldn't find anything on eating in there. So where do you find that?
It's in the reading. It's in your readings under the chapter. Well, I don't have it in front of me, but eating disorders. One of the chapters that you're, hang on, let's pull it up. Hang on. Ah, nope, in the wrong one. Okay, bear with me. My mouse is going too quick. Where is our? Oh, that was from a different book. That's week 5. Oh, hang on a second. Let me go back. Right here. Chapter 47.
Okay.
See that?
Alrighty. Thank you. Yeah.
Okay. Number 9. Which of the following signs and symptoms of alcohol abuse intoxication would the nurse expect to see? What are the two-
Drowsiness and speech.
Say that again.
Drowsiness and slurred speech.
Correct. Obviously, steady gait and alertness wouldn't be right. Okay, that was a pretty easy question. The nurse is caring for a client with a terminal disorder is close to death. In reviewing the plan of care, the nurse determines which action is a priority. So again, another important word, priority. What is the most important
The
aspect that we
client's
as a
dignity and free.
pardon me?
Maintaining the client's dignity and ensuring it's as pain-free as possible.
Yep, and we'll address that more when we talk about the hospice content. That is the most important thing for a hospice patient, just trying to maintain dignity, ensure they are as pain-free as possible. Okay? All right, well, good job. Let's go through the content from week 4 and week 5. I'm just going to bring up your notes here. Can everybody see? Everybody see this? Okay. All right, we're going back to talking about special vulnerable populations. So in general, we know that vulnerable populations have poorer health outcomes, all right, compared to others in terms of morbidity and mortality. We know a few things about vulnerable populations in general. They have more chronic illnesses. Okay, they have higher levels of communicable and infectious diseases. They have a higher incidence of upper respiratory tract infections. They experience higher risks such as poor living conditions, diet, health status. Maybe they live in a neighborhood that's high in, pardon me, crime and violence. Okay. When we talk about special vulnerable populations, one of the populations are pregnant teens. Very high vulnerable population. We know that there's an extremely high correlation between poverty and poor health outcomes with this population. Okay, we know that teens are three times more likely to drop out of school. Okay, we know that, as one of the quiz questions had, if we can increase the opportunities for programs completing their education, chances are definitely increased for a better future, right? If the chances are increased for a better future, that hopefully improves healthcare over the long term or over their lifespan for both mom and children. Right, so as we said, that was your question. We want to keep the pregnant adolescents in school. And we want to actually try and have them return to school after the birth. Okay, we know that pregnant homeless teens are another very high risk group. Okay, higher rates of STDs, higher rates of addictions to substance abuse, alcoholism, mental illnesses, very high risk of poor nutritional status, and higher incidence of poor birth outcomes, whether it's preemie, whether it's low birth weight, birth defects, SIDS, even death. Okay. We know that racial and ethnic minority groups have a higher rate of teen pregnancy. They have a higher, due to the higher rates of poverty, living in poverty, lack of educational opportunities, higher rates of abuse, domestic violence, intimate partner violence, right? Factors contributing to teen pregnancy within the racial and ethnic minority groups. Again, similar to the general population. Low income, maybe living in poverty, lack of education, lack of support system, lack of community resources, increased risk to environmental exposures, maybe abuse in their home, maybe they're a victim of abuse or they're living amongst a family that's abusive, previous trauma, neglect, sexual victimization. Because teen pregnant moms have a higher risk of being involved in domestic violence, if you're working with this group, one of the things you want to do as a teaching tool and a planning tool for this group is to establish a safety plan. And you should have read about safety plans in your notes. Okay, here's what the safety plan includes: bag of clothes, important documents, money, credit card that cannot be traced, spare car keys, phone numbers of nearby shelters, phone numbers of family members or people that need to be contacted. Okay, Another important aspect of working with pregnant teens is after they've had the baby. And let's say you're the home health nurse and you're doing the postpartum visit. What do you think you should be looking for with a new teen mom? If you went into a home, what would you be looking for? What would you be looking for, and what would be the red flags? I'm asking you guys.
Not having furniture for the baby,
Okay.
like baby's basic necessities. If I come in and I don't see a crib or diapers or things
Mhm.
like that,
Okay.
that's
Great.
gonna-
What else? Nobody else has any important thoughts?
Jasmine said, "Are they bonding?" That's important too. Like, is mom and baby doing okay emotionally and like mentally?
Right. That's extremely important, bonding. Does this teen mom know how to respond to the needs of the infant? Right? Do they know when the infant's hungry, needs a diaper change? Okay. Teen mothers do struggle with bonding. Right? Bonding would be looking for, are they holding the baby when the baby cries, especially during feedings, making eye contact, playing with the baby, talking to the baby. What else is going on in the home? Is the dad there? What does that look like? Is it a calm environment? Is it a stressful environment? Does this young mom have the resources she needs? Is there family support? So doing that, those home health visits initially with that teen mom are extremely important. Does the mom have an understanding of what normal growth and development is for the baby? Okay. When we're talking about teen pregnancy, let's go through a couple of examples of primary, secondary, and tertiary. Of course, primary is preventing this from even happening, right? So the one thing we can do as a primary intervention is sex education, right? With these kids early. The sooner the conversations happens, the better. The lower the risk of unintended pregnancy. Secondary, how do we screen for teens that may be at risk for unintended pregnancies? What kinds of things do we look for? Are there behavior issues at school? Is there a history of substance abuse or alcohol with the teen? Is there a reported history of sexual abuse, physical abuse, emotional abuse? Does the teen live in poverty? What other risk factors may put them at risk for an unintended pregnancy? Okay, maybe provide resources for pregnancy screening or pregnancy testing. That's secondary. Okay, and then tertiary, the event's already happened, the teen is pregnant. Okay, so what do we have to do? Find out what the needs of the teen is. Do we need counseling? Do we need access to prenatal care? Do they have a doctor? Okay, do they want abortion information? Do they want adoption information? Are they going back to school? How can we help move this along in a healthy way that is best for the mom and the baby? Okay. When talking with the LGBT population, here's a good example of checking our own feelings. Okay, we do have an ethical obligation to provide culturally competent care to LGBT families. Okay, there may be some nurses that are they're uncomfortable discussing sexual orientation with their clients. So we need to sort through those feelings in order to be able to care for this population. So understanding our own feelings is extremely important to provide competent care, non-judgmental care. Okay, these clients need a safe environment to discuss their sexual orientation, right? We can't be judgmental, we can't be stereotyping, okay? Talking in an open, non-judgmental way to obtain sexual, social history. But first, the key is building trust. Okay, and building trust means that you can openly and therapeutically communicate in a effective, caring, compassionate manner. Right? So for example, maybe you want to ask the question rather than do you have a boyfriend or girlfriend? Maybe you want to say, do you have a partner? What do you call your partner? Or what do you call your partner? Right? Are you in a relationship? Okay, those are open-ended, non-judgmental questions. You're not assuming heterosexuality. And that makes a big difference. Right? And then CDC, there is a suggested annual screening for LGBT population. It involves 5 screens: HIV, genital herpes, syphilis, gonorrhea, and chlamydia. I've highlighted those for you. That is the recommended annual screening. Okay. And this is recommended for and the prevention of STDs. This annual screening is bumped up to a shorter time frame of 3 to 6 months if they're at higher risk. Okay, higher risk is considered individuals with multiple or anonymous sexual partners, or those who use illicit drugs in conjunction with sex. Okay, that's the 2 criteria. But I'd like for you to be aware of what the annual screening protocol is for this population with regards to STDs or prevention, screening of, prevention of. Okay. Mental illness. Okay. Again, the foundation for a good nurse-client relationship must begin with the nurse's thorough understanding and self-awareness of their own beliefs, biases, feelings, and values. You're going to hear that a lot today. Okay. We know that anxiety is common. It is expected, right? It's considered healthy anxiety is considered common. But if it becomes so debilitating that it impairs your functioning of your daily life, then it has to be dealt with. You and I we're all anxious about something at the moment. Can we manage that anxiety in a healthy way? Or is it so debilitating that we can't function with school, function with work? That's when it becomes a problem. Couple of mental health illness diseases or diagnoses I want you to be aware of. I have highlighted these for you. Generalized anxiety disorder, phobia, OCD, PTSD, and somebody with suicidal ideations. Okay? So we know that generalized anxiety disorder is chronic. It develops slowly over time. Okay? People with generalized anxiety disorder worry more than the common person. They often worry about multiple concerns at the same time. Okay? Phobia, an excessive, irrational fear of something specific, a specific activity, a specific situation, a specific object. Right? It can lead to avoidance or extreme anxiety that interferes with your normal daily responsibilities and routines. Okay? For me, I have a phobia of snakes. That's just full disclosure. I will absolutely lose it. Even if the snake is that long, even if it's a worm. Obsessive compulsive disorder. Okay, obsession, recurrent, intrusive thoughts that you can't stop thinking about. And these thoughts create anxiety. Compulsive acts. Okay, I'm just giving you the general, the short version. You guys can go through and read the longer versions. PTSD. Okay, PTSD is an event that either threatened death or serious injury, either to yourself or you saw something, or threat to others. This has caused intense fear, helplessness, horror. Then remember, this is one of your quiz questions. Anxiety, nightmares, flashbacks. Those are recurrent. And then what do you do if you're caring for a client with suicidal ideations? One of the most important things with somebody that's suicidal or has suicidal ideations is safety. You need to be asking the right questions. Do you have a plan? What is your plan? Do you have the resources to carry out your plan? Have you attempted suicide previously? One of the most important interventions for a suicidal client is safety. We know that kids are at the highest risk for mental disorders. Okay. What is their environment? What does their living environment look like? Are they witnessing violence? Are they victims of violence? Okay. Kids are very, very vulnerable for mental disorders. Clients with bipolar disease. That's another one, but what I want to talk about bipolar is the treatment. Lithium. This is the one medication I want you to know about. Okay. Typically for bipolar, lithium is prescribed as a mood stabilizer. And there's a couple of important teaching points. If you're taking care of a client who's just been diagnosed with bipolar and put on lithium. Couple of teaching points: encouraging normal salt intake, reporting diarrhea, vomiting, tremors, or lack of coordination. Okay. So have an understanding of the teaching plan for somebody on lithium. And then we have alcohol, tobacco, and other drug problems. Okay, we know that substance abuse in general contributes to a lot of issues: teen pregnancy, HIV, STDs, domestic violence, child abuse, child neglect, motor vehicle crashes, fights, crime, homicide, suicide. And that's just for starters, right? We all know somebody, whether it's ourselves or family members, friends, coworkers, teammates, school teammates, that have been impacted by substance abuse or alcoholism, right? We all do. Okay. There's a couple of terms here to be familiar with: substance abuse, drug dependence. I'm going to have you go through these, but I want you to understand the difference between them. Substance abuse, drug dependence, drug addiction, alcoholism, polysubstance abuse. Okay. What I want to focus on is substance specifics. Okay, so nicotine, tobacco. We know that nicotine is a toxic substance, right? It's very, very addictive. One of the most addictive. Okay, we know that tobacco contributes to cancer, heart disease, lung disease, emphysema, bronchitis, all sorts of pulmonary respiratory issues. Additionally, if you're smoking when you're pregnant, potential premature birth, low birth weight, stillbirth, infant death, or SIDS. It all has an increase when the pregnant mom is smoking. We know that secondhand smoke, contains more carcinogens and toxins than first stream smoke. Okay. So vaping and e-cigarettes is part of nicotine and tobacco. Okay, we know that the secondhand smoke from vaping and e-cigarettes is toxic. Why is e-cigarettes and vaping so dangerous when children are present? What is it with the vaping and e-cigarettes?
Chemical substance.
The
oil from these vaping and e-cigarettes is actually poisonous to the child. It's actually poison. Okay. So we know that vaping introduces the lungs to chemicals and toxins like nicotine that are associated with lung damage and increase the risk for long-term respiratory illnesses. Right? So there's 8 primary health risks of e-cigarettes: addiction to nicotine, progression to smoking traditional cigarettes, lung damage, unsafe handling of parts of the e-cigarette. That's that's the oil. Appealing to youth, all the advertisement to the younger kids. Right? Potentially changing social norms, making tobacco smoke more acceptable, and then poisoning to children. So what do you do if you are the home health nurse and you're working with a family that has smokes inside the home and the kids have asthma, and you're trying to work with the family or the mother to working towards a smoke-free environment for the kids, right? Let's say the mother says to you, well, don't worry about it. I'm vaping now, or I'm using e-cigarettes now. Is that better? Is that something
No,
that she should be
it
working
works.
towards, or what do you need to tell that mother at that time?
To educate them on what the oil does to the kids.
And the smoke, yeah. That this is not a healthy improvement. It actually can make matters worse, right? Alcohol. We know that alcohol abuse causes billions of dollars in damage in a variety of ways: lost productivity, property damage, medical expenses, alcohol-related illness, accidents, family disruptions, alcohol-related violence, and so on and so on. Right? We know that chronic alcohol abuse affects has numerous physical effects on the body. Right? This is one of your quiz questions about what the liver can metabolize. Okay, but I want to, let's see. Alcohol's metabolized, goes through all. So blood concentration is determined by several things: the concentration of the alcohol in the drink, the rate of the drinking, the rate of absorption, the rate of metabolism, and the person's weight and sex. So it's determined by several factors, right? One of the things, if you're working with substance abuse clients, one of the things you might experience or observe is alcohol. If somebody's going through detox or in recovery, going through withdrawal symptoms. And something that's common in the withdrawal symptoms is delirium tremens. Okay, these look like seizures, right? So one of the things if you're caring for people in withdrawal, you need to be ensuring safety, seizure precautions. That if it's in a facility, that might mean padding the side rails, having IV access in case you need it, having oxygen at the bedside, having suctioning at the bedside. Early on in my nursing career, I worked in a unit that was just for alcohol withdrawal, and saw this all the time. And they look like seizures. These tremens look like seizures. So one of the things you need to consider, or you need to have in place, is seizure precautions, safety precautions. Okay, another addictive substance, cocaine. Okay, produces an increased sense of energy, alertness, elevated mood. Okay, but there are observable side effects of a potential overdose: dilated pupils, high levels of energy and activity, exuberant speech. All right, cocaine is it gives you immediate effects, but they wear off quickly. Okay, and not only does it affect the brain, the heart, and the emotions, but also affects the respiratory system. It affects the GI tract, kidneys, sexual function, right? And then this goes through what withdrawal looks like. After regular cocaine use for a period of time, you're going to see withdrawal symptoms. May include depression, anxiety, fatigue, difficulty concentrating, inability to feel pleasure, maybe an increased craving for the drug as you're withdrawing. Okay? Methamphetamines and amphetamines. Similar to cocaine, but different in a few ways, causing an elevation in mood, increased wakefulness, alertness, concentration, intensified physical performance, a feeling of well-being. Okay, so be able to have a client present to you with either after taking the drug or going through withdrawal, and be able to recognize which kind of drug they've taken. Was it cocaine? Was it an opiate? Be able to recognize the signs and symptoms. Okay, so clinically thinking, if you're presented with taking care of a patient, there's potentially having issues from a illegal drug. Okay. With regards to alcohol, tobacco, and other drugs, a couple of examples of primary prevention. One of the most important things with drugs is harm reduction. Remember that word, harm reduction. It's a primary care approach to substance abuse. A harm reduction focuses on health promotion and disease prevention. Okay, so if you're teaching about harm reduction, like I did with the high schoolers when I was in school nursing, we talked about healthy lifestyles, resiliency factors, education about the dangers of drugs and their potential short and long-term effects, right? Choosing healthy options rather than reliance on drugs. Okay? Secondary prevention, how do you screen for at-risk clients? Well, in high school, we actually looked at what their behavioral and academic records look like, right? What their family dynamics look like. Okay, are there parents or people in the house that abuse drugs? They have older siblings that abuse drugs, right? So again, screening. Okay, and then typically with tertiary, they already have an issue. So what are some of the things we might observe? Lying about their use, minimizing how much they use, blaming others or rationalizing why they're doing it, intellectualizing, changing the subject, using anger, humor. Okay, and then the term going with the flow, right? They acknowledge what's going on, but not really demonstrating any behaviors that would tell you that they're changing. Okay? And then have a look at this list. If you're a community nurse and you're working with primary prevention techniques or interventions for your community or the kids, if you're working in the schools and you're working with the kids, here's a nice list of community-based activities aimed at substance abuse prevention. Okay, so have a look at that. Okay, some high-risk groups, adolescents, right? High-risk groups. These are groups with the likelihood of adverse health outcomes and or have a higher risk of addiction. Adolescents. We know adolescents like to experiment. It's a natural part of their development. Alcohol use, marijuana use, opiate use, right? These drugs can interfere with their normal growth and development. Maybe there's other mental health comorbidities, psychiatric issues, family problems, genetic predispositions, meaning hereditary. They have a family history of drug abuse or alcoholism. Older adults are also a high-risk group, higher rates of alcoholism. And often, alcoholism can be mistaken for cognitive issues. Pregnant women, another high-risk group. Or pregnant women or mothers, fear of losing their children with addiction issues, maybe the stigmatization, maybe the risk of fetal alcohol syndrome. They were drinking while they were pregnant, or if there were complications at birth. And then the last high-risk group is the injection drug users. They're at risk for overdose, contaminated needles, which potentially lead to HIV, hepatitis C, or maybe the chemical contamination of drugs. You know, all those drugs that are mixed and you don't know what's in them, that potentially is a big problem. Okay. So that is our week 4 content. Do we have any questions about special vulnerable populations? Teen pregnancy, mental illness, alcohol, tobacco, and other drugs. And if you're working in the community, whether it be the schools or group homes or rehab facilities or detox facilities, these are the clients you're going to be working with. Or if you're working in the community with new families, new moms, pregnant, new teen moms, very vulnerable. You need a lot of help and a lot of resources. Let's jump into this week, hospice and palliative care. Okay, so this is one of our quiz questions. The nurse needs to focus on the needs of the client to keep them comfortable, maintain dignity and self-esteem. However, one thing is important to know about pain control. We don't want them, with regards to pain control, we don't want to keep them so sedated that they are totally unaware of what's happening, right? If they're in hospice, we want them to try to be interacting with their family, friends, relatives as much as they can. We also want them to have pain relief, but also we want them to try and contribute as much as they can to the decision making for themselves, right? Give them as much autonomy as possible. Okay? We also know that hopefully the clients have verbalized what their needs and wants are as they go through the hospice process, but we also have family and relatives involved who sometimes may not agree with what the client wants to do, right? But we have to remember that the client's needs, the client's desires take primary precedence. Okay, and you hear this a lot from hospice nurses. Yes, they're crystal clear on what the patient wants, but sometimes the family members just don't have an understanding of why they chose that or why they don't want this. So I guess my point is the hospice nurse has a client, but her other clients are the family members, right? Obviously, we're trying to alleviate as much suffering as possible. But one thing we need to understand in hospice and palliative care is there's no cure. Okay, this is end of life care. So we're trying to improve the quality of life versus the quantity. All aggressive treatments have been stopped. Okay? Accepting that death is normal and expected and trying to humanize the experience is what we work with the clients to understand. If they desire spiritual care or spiritual support, we need to provide that. Do they belong to a religious group, a congregation, a church, a temple, a mosque? Do we need to get spiritual care involved with them so they can talk through whatever issues the client may have with regards to their spirituality? Okay. Oh, what else? Physical. Here's some kinds of support we can provide. With regards to physical, alleviate pain, try and reduce air hunger, and try and improve sleep. Social support, try and help facilitate relationships that may be strained or neglected. Maybe the patient wants to try and mend some relationships. Maybe we're working with them to update their will. You know, calling loved ones to come and visit, say goodbye. And then the spiritual support, but helping them find their peace, whatever that is, with God or a higher power through a spiritual advisor. Another thing to understand with regards to the hospice nurses, they have to have an understanding of the stages of grief. Everybody's going to be in a potentially different stage, the client, the family members. So what do you do in each stage? What kind of support does the client and or the family need in each stage? Okay, so please have an understanding. This paragraph here talks about the stages of grief. So have a look at that. Okay, one of the things we don't want to do in hospice and palliative care is we don't want to make decisions for the family or the client if they're capable of making them. Okay, it removes any kind of autonomy that's left. We do not want to be making decisions for them. Okay, we want to be encouraging all family members. It's hard, but if you have family members that are not on board or having a hard time accepting what's going on, the hospice nurse can talk with those family members, find out what is going on, what will help bring them along to have an understanding of where the current situation is. Has anybody ever worked alongside a hospice nurse or been involved with hospice with a family member? I've done both sides. Work with hospice clients and have family members in hospice. It is amazing, the hospice process. Amazing, both as a caregiver and a family member. Has anybody had any experiences with this?
I work in long-term care, and hospice comes in and works beside us 3 days a week for the patients that are on hospice. And it is
Okay.
really nice because I feel like they get not like extra attention per se, but when, you've got 2 aides to 36 people, it's harder to get down and do their nails each time and do their hair each time.
Mhm.
And they come in and really pay very special attention to what they like and making them feel good and making them feel comfortable. And it helps us too because it's harder to be able to put the people already. So it's nice
Right.
it's comforting to know that they're there to help with that stuff.
And then the family members. They work with the family members as well, do they not?
I'm sorry, you cut out.
Oh, sorry, family members.
Mhm.
They're involved with the family members.
They're in there.
Yeah.
Yep. And it's nice because they'll even do I don't know, just little extra things that I feel I don't see with just simply the long-term care clients or
Right.
just the skilled people that are in there for a week or two. They go above and beyond for them, and they get the family involved, and they really make sure that like the last 6 months are like the best 6 months possible.
Right.
And I love into it.
Yeah.
It's
Yeah.
really important.
Yeah. Yeah. That's awesome. Thank you so much for sharing. I appreciate it.
Mhm.
One of the other topics to cover this week is culturally competent care. Okay. Culturally competent care is evolving. It will be evolving through our whole nursing profession. I've been in nursing for 40 years, and my cultural competence is still evolving as I'm learning about new cultures. All right. Culturally competent care. I'm going to start with this first statement, and then we'll go back. All right. Cultural competence We grasp it, we attain it. When we, as nurses, consistently make a conscious attempt to learn about people and cultures and look at the world through their perspective. We all in our nursing professions work with different cultures. Okay, our culture, my culture, is no more important than your culture. Okay, we can make no assumptions about other cultures. We cannot place our culture above my culture above anybody else's or your culture. Everybody is considered unique. Okay, we try and incorporate, each culture has their own values, beliefs, practices, communication, food preferences. We need to try and incorporate as much of our clients and their families' culture into the plan of care. There are some things that maybe we can't do, but most we can. And we need to be sensitive to try and incorporate as much of their culture into the care. We also know that some cultures are past, this is time related. They're focused on the past, the present, or the future. Okay, so if we have past oriented cultures, right, they may value their ancestors and sometimes have such a preoccupation with past events that it's difficult for them to think ahead and plan for their future goals. Okay, present oriented cultures, they're focused on the here and the now. Their priority is their quality of life here, now, and today. Okay, whatever makes them happy in the present. This can also fail to plan for the future, right? Or consider future consequences. And I'm not saying it's right or wrong. I'm just saying that different cultures have different time perceptions. Future-oriented cultures, they are much more likely to make sacrifices now in the present so that they can attain their future long-term goals. So what I want you to know is that there are 3 different time orientations: past, present, and future. Okay? Cultural competence requires that we approach each client as if they're unique. I said that. Gather data on their beliefs, not treating every client as we would want to be treated or expect, because our cultures are so vastly different. Right? We don't want to just learn about minority cultures. We want to learn about all cultures. Okay? Here's a few examples of specific cultural practices. Native Americans, they don't like to sustain eye contact in the same way European Americans do. They consider that rude. Jehovah's Witnesses, we've heard about. They're not opposed to surgery, but they're opposed to any blood products given before surgery, during surgery, after surgery. It's not part of their culture. Okay? And then another example is Jewish clients who follow a kosher diet. Okay, they avoid pork products, any kind of meat from carnivores. Okay? They focus on fruits and vegetables, chicken, tuna, potatoes, things like that. Okay, so being aware of one's own culture is important, but we are always evolving as nurses and learning about different cultures. I'm still learning about different cultures. Okay? Faith community nurse is basically a nurse who works within the faith community, whatever that faith community is. Whether you're working with a church, a temple, a mosque, whatever your faith, whatever that community is. A faith community nurse works within that congregation and is usually focused on holistic health promotion, adds the spiritual touch to the care. And they're involved with whatever their duties, or whatever the congregation's needs are. I have a couple of friends who are faith nurses, in local churches. They've been doing it for years. They do everything from new baby visits, whether it's a teen, any age group of a mom. They do their new visits. Do they have the resources? Do they have the education? Do they have the supplies? They do grief support groups for family members that have died. They may do substance abuse support groups, health fairs, screenings. It's whatever the congregation's needs are, but it's typically focused on primary. Okay. And then the last part is legal and ethical issues. Okay. So the first, we have legal and ethical, we have ethical issues that we deal with all the time. Right? What is ethics? To do good, right? To do the best. Ethically, we make the best decisions that we think are morally correct. Right? So if we are working, think of the nursing process here. The first step in ethical decision making is, what's the issue? Is it an end of life issue? Is it the way the client's being treated by a partner or family issue? What is the issue that you're being faced with? Okay, then we look at our nursing process. We try and obtain the relevant facts. We try and think of what the needs are, what approaches, what's the plan? Try and implement that plan, and then evaluate the action or evaluate the outcome of our actions. Okay, so ethical decision making is a process. The other thing we deal with all the time is moral distress. We have moral distress in our work life probably every time we go to work, whether it be staffing issues, too much of a patient load, you're worried about the quality of care you're going to give. I've had a couple students who work in correctional facilities, moral distress from some of the clients in the correctional facility that they're asked to care for. You know, if they've murdered somebody or raped somebody. I mean, these are moral issues. We face them all the time, right? So moral distress is really defined as experience when an individual is unable to act in accordance with what one believes to be the right course of action. So moral distress could be you are morally distressed when you go to work tonight because you realize 2 of your teammates have called in sick and you're responsible for the whole floor and there's no help coming. Is that morally distressful for you? Of course it is, because not only, it's not so much the workload, but are you going to be able to deliver safe and effective care? Right. Right? Moral distress is a burden for all nurses at some time or another. Can lead to burnout, leaving the profession if you can't deal with it or if it hasn't been dealt with. Okay? Examples of moral distress: end of life decision, patient load too high. Remember all the COVID visitor restrictions where nobody could come in and people are dying alone. Okay, couple of ethical principles. Beneficence, this four important ones. I like to talk about beneficence and non-malfeasance. Beneficence does require that we do good. We do good, the most good possible within the circumstances. So an example would be adequate pain control. We do good. Non-malfeasance, do no harm. It is our ethical responsibility to practice non-malfeasance, do no harm. The example It's not in here, but the example I give is, let's say you're cathing a patient. Let's say you're cathing a patient and you contaminate the field. What do?
You
Go get another,
restart.
go get another kit and restart, right? Do no harm. There's another ethical principle of autonomy. That is respecting the client's participation in their plan of care. You want them to be autonomous. And then the last is distributive justice. Everybody has the right to the same resources, to distribute equally what's available. Advocacy is another important term in ethics. Advocacy is the nursing practice of using all the information and resources that we have to benefit the client. We are acting in the client's best interest. Okay? We're maintaining confidentiality. We're acting impartially. We're carrying out the preferences and the goals of the client with competence. Right? Making sure the client receives relevant information prior to surgery. Making sure they understand side effects of medication. Okay, being an advocate for our clients. And a couple of legal nursing actions that I want to talk about. Documentation and floating. We know documentation can only be factual. It can't be, well, they seem to be sad today. They seem to be angry today. They appear to be troubled today. Those are our opinions. Though that's not what gets documented. Okay? What gets documented is factual information, what you see, what you hear, what you feel, what you smell. The wound was draining pinkish purulent drainage. It was foul smelling. The patient stated, "I feel sad today." I overheard the family member telling the patient. Does that make sense? That's factual. We can't be putting in our opinions or what we think. You know, the patient was cranky this morning. Well, what if they didn't sleep all night? And you're the new nurse coming on at 7 and somebody forgot to report off they hadn't slept all night. They had a very unsettling night. They didn't sleep. So it's not up to you. Oh, the patient seems like they're angry this morning. Does that make sense? I spoke with the patient. Here would be a better way. I spoke with the patient about their comments about being angry. Patient stated, "I was up all night. I've been so much pain. I can't get my pain under control." That's factual information. And then another legal issue would be floating. Anybody been asked to float to a different unit? What if you're floating? Let's say you work on an adult unit and you're floating to peds. Okay, you can't refuse to float. But what you can do is identify what actions you can perform safely. Right? And that's a discussion you would have with that leader, manager, shift nurse, right? Identify potential areas that you can safely perform and identify areas that you are not safe at. You've never done pediatric vital signs. You've never done pediatric nebulizer treatments. But you can hand out the food trays. You can help prepare for discharge. You can do a bath, whatever. Does that make sense? So those are some legal issues.
So if the question stated, then you were asked to float to a different floor, but it's a floor you're not educated on, the answer would be that you just need to identify the tasks that you can do safely?
Yeah.
Okay.
That would be a discussion with the whoever's leading the floor that day. Hi, I'm Skylar. I'm floating to you, but here's my experience and here's what I'm comfortable doing on your unit. And here's what I don't feel comfortable doing, because remember, you are operating under somebody else's license. Right? So you
Okay.
need to be crystal clear on what you feel competent about doing and what you're not competent in doing. As a nurse manager, for me, I would have to listen very intently to you and make sure I assign you tasks that you can do. Right?
Also, in the practice apps, is looking as incompetence. Refuses looking as incompetence.
Well, you can't really refuse to, I mean, unless you're part of a union that has a contract that said you don't float, that can cover you, but you can be floated. I don't think you can refuse to float. Right? You can't refuse to float. You just have to advocate for yourself and what you're comfortable doing and what you're not. Okay? So a lot involved in ethics and legal. Okay? So okay, well, that is all I have for today. I'm going to be along. I have a Kahoot for weeks 4 and 5 for this class. We just don't have time to do it. I'm going to send the Kahoot to you with the recording. All right, so when I send you a recording of this class, I'll send you the Kahoot and you can do it on your own. I've heard from the Monday class, it's really helpful. So I'll send that along to you. Okay? Any questions? We covered a lot today. Did you learn a lot? I like teaching this in this particular week. I like talking about faith, community, and cultural
And I always love
competence.
like,
Pardon me?
yes. And I always love like the mental health and substance abuse
Yeah,
stuff.
yeah,
I
yeah, yeah.
really enjoy
Think about the
that.
community. Think about working in the community. Think about how much of that is in the community. All right. Well, listen, you guys have a good weekend. Clarence, is Clarence still there? Yep. Stay on. If anybody has any questions, stay on. Otherwise, have a great weekend. Okay. Good to see everybody.
Thank you. Have a good
All
one.
right.